Greetings to everyone. Here are the corrections of the pediatrics questions that were sent to you the other day. These questions are given to you by Excellence Academy, the reference bilingual group by Excellence, specialized in mentorship, orientation, and preparation of the residency concours in Cameroon and abroad. Here are the instructions. Each question or statement below is followed by several propositions. Select the statement that best answers the question or best completes the statement. Question 1. As the city's public health worker, you have been tasked with screening children at high risk for lead poisoning. Which of the following tests is the best screening test for this purpose? A. Careful physical examination of each infant and child. Red blood cell protoporphyrin level. Complete blood count and blood smear. Blood lead level. Environmental history. So we need to know that the best screening test for lead poisoning is in high risk children is the blood lead level. Is the blood lead level test. So the blood lead measuring the blood lead level is the gold standard for screening lead poisoning, as it directly quantifies lead exposure and helps identify children who need medical or environmental intervention. Option A. Thorough physical examination. It is useful but does not detect lead poisoning early. Erythrocyte protoporphyrin level is an indirect indicator that may be delayed relative to lead exposure, so it is not appropriate here. Complete blood count and blood smear may show anemia but are not specific to lead poisoning. And environmental history is important for assessing risks but does not confirm lead poisoning. So the best option here is D, blood lead level. Excuse me. Question 2. A 3-day-old newborn baby is seen in the pediatrician's office for staph infection. On physical examination, the pustules measure about 3 centimeters, are filled with a milky liquid, are hissed off and reveal a small underlying hyperpigmented macule. What is the most likely diagnosis? A. Salmon patch. B. Milia. C. Seborrheic dermatitis. D. Pustular melanosis. E. Toxic erythema. So, looking at this clinical picture, the most likely diagnosis is transient neonatal pustular melanosis. And we need to know that transient neonatal pustular melanosis is a benign condition present at birth, characterized by superficial pustules filled with clear or milky fluid. These pustules rupture easily, leaving behind hyperpigmented macules, which matches the description given in this question too. It is more common in darker-skinned newborns and requires no treatment. The option A is not correct because salmon packs they are made up of pinkish red macules on the forehead, eyelid, or nape of the neck, but don't have pustules. Milia constitutes small, pale-like white papules without pustules or residual hyperpigmentation. Option C2 is not correct because seborrheic dermatitis corresponds to yellowish, greasy scales on the scalp and folds and does not contain pustules. For toxic erythema corresponds to erythematous papules or pustules on a red background but with no residual hyperpigmentation. Question 3. A 3-year-old boy wakes up every evening around 2 a.m. screaming incoherently. His parents report that when they watch him, he is restless, seems awake but is unresponsive, and goes back to sleep within minutes. He has no remembrance of the episodes in the morning. What is the most compatible nighttime disturbance with the history? A. Night terrors. B. Nightmares. C. Obstructive sleep apnea. D. Temporal lobe attacks. E. Somniloquy. Excuse me. So, looking at this clinical picture, the most likely sleep disturbance is night terrors. Why night terrors? Night terrors are a type of parasomnia that typically occurs in children between ages 2 and 6. This child is 3 years old, so lies well in that interval. They happen in the first half of the night during slow wave sleep, that is stage N3. The child wakes up screaming, appears awake but is confused, does not respond to stimuli, and falls back asleep quickly. In the morning, they have no memory of the episode. Option B talks about nightmares. Nightmares occur in the second half of the night, and the child remembers the dream upon waking. So that is not. So nightmares cannot be the option here because they said when the child wakes up, he has no remembrance. Option C talks about obstructive sleep apnea. Obstructive sleep apnea is associated with snoring, breathing pauses, and daytime sleepiness. So that is not consistent with the picture given here. Option D talks about temporal lobe attacks. So temporal lobe attacks or seizures may cause nighttime awakenings, but often include auras, automatisms, or abnormal electroencephalogram findings. Somniloquy, also called sleep talking, involves talking during sleep but does not involve intense agitation or confusion upon waking. Question 4. An 11-year-old boy is seen by the pediatrician for an assessment of the healthy child. He is in good health and reports no illness. He reports that he helps care for his elder brother's 3-week-old twin girls. His physical examination is normal. What group of immunizations is most likely needed for this child? A. Measles vaccine alone. B. Vaccine against measles, mumps, rubella, and chickenpox. C. Meningococcal, tetanus, diphtheria, and pertussis vaccine. D. 23-valent pneumococcal vaccine. E. None of the above. So the most likely vaccine required here or for this 11-year-old child is the meningococcal, tetanus, diphtheria, and pertussis vaccines. Why? Because at the age of 11, the recommended vaccines are effectively the TDAP booster, associating tetanus, diphtheria, and pertussis. So a dose at this age will boost the immunity against pertussis, which is particularly dangerous for infants, such as the brother's twin newborns mentioned here. So another vaccine that is recommended at the age 11-12 is the meningococcal vaccine to protect against bacterial meningitis. The measles vaccine alone is not recommended separately. Instead, measles vaccination is given as part of the measles, mumps, and rubella vaccine. Option B, the measles, mumps, rubella, and varicella vaccine are typically given at ages 1 and between 4 to 6 years. A booster at 11 is unnecessary unless the child is under-vaccinated. Option D, the 23-valent pneumococcal vaccine is recommended only for children at high risk. For example, children with sickle cell disease or another form of immunodeficiency. So the best answer here remains the C option. Question 5. A 14-year-old child with a history of ulcerative colitis, lack of appetite, abdominal pain, diarrhea, rash, and irritability is seen by a pediatrician. On examination, the tongue is erythematous and smooth with loss of papillae. The skin has sharp red areas with large blisters, especially in areas exposed to the sun. In older areas, the rash is dark and brown. The muscles are weak and the gait is abnormal. What is the dietary deficiency most likely to be responsible for this child's condition? A. Folate deficiency. B. Thiamine deficiency. C. Niacin deficiency. D. Vitamin B12 deficiency. E. Vitamin B6 deficiency. So, how to arrive the right answer here? Looking at this description, for those who have tried to investigate, you see that the best answer there is deficiency in niacin. Niacin deficiency, which is also known as vitamin B3. So niacin deficiency can lead to a condition known as pellagra, which is characterized by the classic triad of dermatitis, dementia, and diarrhea. So the child's clinical symptoms including gastrointestinal issues, erythematous tongue with loss of papillae, skin lesions and irritability are consistent with niacin deficiency. So the other options, folate deficiency can cause symptoms like megaloblastic anemia and gastrointestinal issues, but does not explain the characteristic skin eruption and other symptoms as described in this case. The B option, the thiamine deficiency, causes a condition known as beriberi, which is associated with severe neurological symptoms such as confusion, muscle weakness, and heart failure, but not characteristic skin lesions. Vitamin B12 deficiency can lead to anemia and neurological issues, but does not cause the typical skin eruptions seen in pellagra. Vitamin B6 deficiency can cause seborrheic dermatitis and neurological issues, but does not match the combination of skin lesions and gastrointestinal symptoms seen in this clinical picture. So that is what I can give you as correction for these questions of pediatrics. And just as would always recall that for you to achieve your set goals, to actualize your set goals, you always need to combine discipline and consistency. For discipline and consistency constitute the sole bridge between set goals and their achievement. So consider subscribing to this YouTube channel and click on the notification to get early updates of our new videos. Thank you.